Assalamualaikum and good afternoon. For this month punya journal review, we have Athirah to talk about last year's AHA-ASA's guidelines for the management of SAH. Okay, I think in the interest of time, we will just start. Okay. Athirah.
Thank you, Dr. Amir and my fellow colleague. So today we will be discussing about the 2023 guideline for the management of patient with aneurysmal subarachnoid hemorrhage. So the significance of this aneurysmal subarachnoid hemorrhage, so it usually afflicts individual in their working years. So the average age is 55 years old. Okay, so aneurysmal subarachnoid hemorrhage usually afflicts individuals in their working years. So the average age is 55 years old. And 26% of patients will actually die before arriving to the hospital. And 13% of patients will die during hospitalization. So there are a few major risk factors predispose patient to this aneurysmal SAH. First is family history. 25% prevalence of harboring a cerebral aneurysm in individuals with 2 or more first-degree relatives with non-cerebral aneurysm. Second risk factors is hypertension, and the third is smoking tobacco. So, according to this guideline, it is cost-effective to perform radiological screening every 5 to 7 years for individual 20 to 18 years old with the major risk factor of family history with non-cerebral aneurysm. Next, we're going to talk about the mechanism of aneurysmal SAH-associated brain injury. So the next subsequent slide, you will see a lot of this delayed cerebral ischemia or DCI. So this is the major aneurysmal SAH associated brain injury. So the pathophysiology of delayed cerebral ischemia are, first is arteriolar constriction, second is cerebral microembolism, third is cortical spreading depolarization. Actually, this is a phenomenon where it occurs after an inciting neurological injury, characterized by, first is there is spreading loss of ion hemostasis. As you all know, ion hemostasis is important for electrical activity in the brain. Second is there's a change in the synaptic architecture, which will cause subsequent depression in electrical activity. The fourth one is blood-brain barrier breakdown, then cerebral autoregulation impairment, and capillary transit time heterogeneity. So this aneurysmal SAH will cause chronic morbidity in the following. So it will cause delayed cognitive recovery, mood disorders, and impairment in the quality of life. Then strategies for reduction in case of fatality and improved outcome. So there are a few guidelines that is listed in this. First one is early repair of the ruptured aneurysm, and then management of patient in special neurological ICU with multidisciplinary clinical group. And then focus treatment of the complication of SAH itself, which are cerebral edema, hydrocephalus, and elevated ICP. Treatment of delayed cerebral ischemia, and treatment of medical complications. So I will explain this further in the following slide. So how would you diagnose and evaluate patient with aneurysmal subarachnoid hemorrhage? First is you have to perform initial assessment checklist. So clerk the patient or the witness or the family members thoroughly. Ask about the time of this symptom onset. Patient will be presented usually with the symptoms of headache. They'll describe it as the worst headache in their life, and then sudden onset, and it's sentinel in nature. And then there's also presence of new neurological deficit. And then you can filter the patient according to this Ottawa SAH rule in the brown box beside. So for alert patient more than 15 years old with severe non-traumatic headache reaching maximum intensity within 1 hour, so patient, you should have a very high suspicion of SAH. So if they meet any of these following criteria, first is patient age more than 40 years old, when there's presence of neck pain or neck stiffness, when there's witness LOC, And the onset of the headache is during exertion, when patient claim that the headache is thunderclap in nature, when there's instant peaking pain, and when you examine the patient, there's limited neck flexion. So actually Ottawa SAH rule is a class 2B recommendation for identifying high-risk patient, and this is 100% sensitive in detecting aneurysmal SAH. So for patients with aneurysmal SAH, care should be provided in a dedicated neurocritical care unit by a multidisciplinary team. And then blood pressure control with an unsecured aneurysm. Actually, the target BP is individualized according to the BP at presentation, whether there's presence of cerebral edema, hydrocephalus, or patient's medical history, whether there's history of hypertension or renal impairment. So you should avoid hypertension, hypotension, and minimize blood pressure variability. So according to this AHA guideline, the BP should be controlled with frequent monitoring and by using a short-acting medications. So next is attaining hemostasis. Okay, so emergent anticoagulation reversal with appropriate reversal agent should be performed to prevent rebleeding in patient receiving anticoagulants who develop aneurysmal subarenous hemorrhage. And routine use of antifibrinolytic therapy is not useful to improve functional outcome. So the treatment for ruptured cerebral aneurysm. So the general principles are ruptured aneurysmal SAH should be evaluated by specialists with endovascular and or neurosurgical expertise. And patient deemed salvageable and with depressed level of consciousness due to large intraparenchymal hemorrhage should undergo emergent clot evacuation or EOC to reduce mortality. So next, we'll focus on most of our part that will do in OT. So surgical and endovascular treatment in terms of anesthetic management. So actually there are limited studies evaluating intraoperative anesthetic management of patient undergoing ruptured aneurysm repair. So in patient receiving a GA, a balanced technique using a combination of medication to provide hypnosis, analgesia, and amnesia while preventing patient movement is commonly used. So infusion of certain hypnotic and analgesic medication might best be administered through continuous infusion to maintain a stable anesthetic state. So the goals of our intraoperative goals include hemodynamic stability, favorable ventilator strategies, and absolute paralysis during exposure, clipping, and also coils deployment. In some centers, sedation may be more advantageous for patient, especially with significant systemic medical condition. However, outcome data are lacking, and neuro-NS may limit the severity of complications by efficiently managing anticoagulation and maintaining systemic and cerebral hemodynamics. So according to the class of recommendation that I've shown earlier, first is the choice of fluid therapy. What fluid should you choose? So hypoosmotic fluids are generally avoided, whereas isoosmotic and sometimes hyperosmotic fluids are favored. So your hypoosmotic fluids such as mannitol and hypertonic saline has been used to decrease ICP and increase cerebral blood flow and promote brain relaxation. Second is post-op nausea and vomiting. The incidence of PONV after craniotomy can be up to 70% of patients. So a multimodal regime of medication targeting different chemoreceptors is recommended. So although we commonly use serotonin receptor antagonists such as ondansetron or gradisetron and steroids such as dexamethasone, the addition of propofol, reduction of your opioids, and promotion of euvolemia are generally advocated. So the use of volatile inhalational agent has been associated with higher incidence of PONV compared to IV agents such as propofol, and dexmedetomidine may offer advantage compared to fentanyl. Third is glycemic control and prevention of hypothermia. So poor perioperative glycemic control in patients with aneurysmal SAH has been associated with increased risk of poor clinical outcome. So a post hoc analysis of this one trial, AHA-ASA trial, determined that commonly encountered hyperglycemia was associated with long-term changes in cognition and gross neurological function. And then our fourth target is in terms of intraoperative volume status and BP goals. So numerous pathophysiological states may be present after aneurysmal rupture, such as CVS dysfunction, systemic inflammation, and autoregulatory failure. So that can be affected by intravascular volume. So during intra-op period, frequent BP monitoring and BP control are important to prevent ischemia and re-rupture. Hypovolumic states often require additional pressure support, especially post-op. The clinical management necessitates hypertensive therapy. So there are suggestions that hypovolemia in the perioperative state may contribute to the incidence of DCI, delayed cerebral ischemia, while hypervolemia lacks benefit and the rapid reduction of BP is potentially harmful. So the fifth recommendation is intraoperative neuromonitoring, though we didn't actually practice here. So common intraoperative neuromonitoring modalities used are spontaneous EEG and somatosensory evoke and motor evoke potential. So pharmacologically induced EEG burst suppression, such as the use of higher MAC of your volatile agent, may be reasonable during temporary clipping if hypotension can be avoided. So the sixth recommendation is the use of adenosine. So it is used for temporary profound hypotension, which may facilitate exposure and aneurysm clip placement in selected situation, especially in the setting of uncontrolled intra-op rupture. So since its clinical onset is within seconds, it will provide a very brief period of profound systemic hypotension with a low side effect profile. So there are a few studies done showing the effectiveness of the use of adenosine intraoperatively. So this first study by the Eric et al., the total data of 29 patients undergo this clipping of aneurysmal subarachnoid hemorrhage. 100% of the patient achieve successful clipping with the mean dose of adenosine of 51.8 mg. Regarding the adenosine dosage, so another one study done in Korea by Sang et al. So it compares two different methods of administering adenosine with different dose. First is in test incremental manner. They started with 6 to 12 mg and then giving additional doses as needed. And another half of the patient, they give estimated manner according to the weight, 0.3 to 0.4 mg per kilo in another half of the patient, in another 11 patient. So they found out that this estimated manner by weight injection of adenosine was more convenient and it result in less serious cardiologic problem. So the last recommendation is avoidance of systemic hypothermia. So it has been studied to attenuate ischemic injury during aneurysm surgery. So although earlier study it promote the systemic hypothermia, a multi-center prospective RCT that evaluated 1,000 patients with good grade SAH found no improvement in 3 months neurological outcome after surgery. So next is we're going to take a look at the management of medical complication associated with aneurysmal SAH. So SAH patient with medical complication has worse outcomes. So first is ARDS. 3.6% of aneurysmal SAH patient will develop ARDS within the first 7 days. And then ventilated care bundle should be practiced in all patients. So the criteria of ventilator care bundle includes optimum ventilator strategy, So the use of low tidal volume with moderate PEEP, and then daily assessment of readiness of extubation, prescribed strengthened antibiotic for HAP, and early enteral nutrition. So this will help in reducing the duration of mechanical ventilation and reduction in the HAP. So for severe ARDS with hypoxemia in ASAH patient, so prone positioning and alveolar recruitment maneuvers should be performed with ICP monitoring. Next is intravascular volume and electrolyte management. So actually, extensive evidence suggests that CVP monitoring correlates poorly with intravascular blood volume, and it is unable to predict hemodynamic response. So intravascular volume in depletion in ASAH can occur as a result of natriuresis and may be associated with DCI and poor outcome. So early goal-directed treatment using continuous monitoring such as cardiac output monitoring, free load, SVV, stroke volume variation can increase the detection and treatment of dehydration or intravascular volume depletion compared to any conventional method. So hyponatremia with or without polyuria or natriuresis is a prominent clinical feature in aneurysmal SAH, but has been inconsistently associated with DCI and poor outcome. So, and then regarding the use of steroid, several moderately sized RCT found fludrocortisone to be effective in reducing excess sodium excretion, urine volume, hyponatremia, and IV fluid use during acute aneurysmal SAH. So other alternative, including high-dose hydrocortisone, have been studied and demonstrated similar effect on serum sodium, urinary sodium secretion, and natriuresis, but reported more medical complications such as hyperglycemia, hypokalemia, GI hemorrhage, and CCF. So, and then, in patient with aneurysmal SAH whose ruptured aneurysm has been secured, VTE prophylaxis is recommended to reduce the risk of venous thromboembolism. And then effective glycemic control, strict hyperglycemia management, and avoidance of hypoglycemia is reasonable to improve outcome. And in patient with aneurysmal SAH with fever, which is refractory to antipyretic medication, the effectiveness of therapeutic temperature management during the acute phase of ASAH is still uncertain. So prevention of secondary problem. So you should perform frequent neurological assessment, frequent vital sign and neurological monitoring, and then provide aspiration prevention, validated dysphagia screening protocol prior to initiation of oral intake, and early evidence-based mobility algorithm once aneurysm is secured. So actually, management of patient with cerebral vasospasm and delayed cerebral ischemia after SAH. As you would see, some of the patient post-clipping would be prescribed this nimodipine by the neurosurgical. So patient with aneurysmal subaneurysmal hemorrhage should be prescribed with oral nimodipine, and then perform regular neurological exams. If there's unreliable neurological exam, perform transcranial Doppler monitoring or continuous EEG. And you should avoid prophylactic hemodynamic augmentation. And when there is worsening neurological or on monitoring when neurological exam is unreliable, when the patient has cerebral vasospasm, you should proceed to endovascular rescue therapy with spasmolytic or angioplasty. So next is management of hydrocephalus associated with aneurysmal subaneurysmal hemorrhage. So actually 15 to 87% of patients with aneurysmal SAH will develop acute hydrocephalus. This should warrant urgent CSF diversion with either EVD or extraventricular drainage or lumbar drain. In patients with persistent or chronic hydrocephalus, permanent CSF diversion is required. So, extraventricular drainage or lumbar drain. So, there's one study shows that although EVD has been regarded as the gold standard for hydrocephalus, lumbar drain may impact the rate of delayed cerebral ischemia due to preferential clearing of the subaneurysmal blood. So according to the data that they've collected, as you can see for lumbar drain group, lesser patient develop delayed cerebral ischemia. Okay. So management of seizures associated with aneurysmal subarenal hemorrhage. Patients who are not presented with seizure at presentation, perform neurological examination. Patient with fluctuating neurological exam, depressed mental state, and with high-risk seizure features such as ruptured MCA aneurysm, high-grade SAH, intracerebral hemorrhage, hydrocephalus, and cortical infarction. You should perform continuous EEG monitoring to detect seizures. It may be reasonable to consider prophylactic anti-seizure medication in patients with high-risk seizure. However, it is found out that phenytoin is associated with excess morbidity and mortality. And then patient without high-risk seizure features, you should not prescribe prophylactic anti-seizure medication as it won't be beneficial for patient. So there's two famous anti-seizure that has been prescribed especially here. So phenytoin versus Keppra or levetiracetam. So poorer cognitive function has been related to phenytoin administration. There's a single-blinded randomized control study of Keppra versus phenytoin demonstrated the same outcome with respect to mortality or seizure control as evaluated by CEEG. However, therapy with Keppra resulted in lower incidence of adverse effect. And the excess morbidity associated with phenytoin should prompt the use of alternative anti-seizure medication. So for how long should you prescribe this anti-epileptic or anti-seizure medication? So recent meta-analysis suggests that compared with short-term use of less than 3 days, the long-term use of more than 3 days of prophylactic anti-seizure medication has similar effect on in-hospital seizure prevention. However, it is associated with poor clinical outcome. So, if patient presented with seizure at the time of presentation, so you should treat the patient with anti-seizure medication for less than 7 days. And then treatment with anti-seizure beyond 7 days is not effective for primary or secondary prevention of seizure in patient with no prior epilepsy. So early seizure is within first 7 days, late seizure is after 7 days. So it is distinct, this late seizure is distinct from early onset seizure as they are not the immediate result of the initial hemorrhage and potentially are related to the treatment modality or post-hemorrhage infarct. So hence, late seizure warrant longer term of anti-seizure medication. So for acute recovery, so there's a few predictive scores that you can use. The use of validated grading scores prior to hospital discharge is recommended to screen for physical, cognitive, behavioral, and quality of life deficits. There are a few questionnaires or grading score that is available to assess whether the prediction of mortality and 3-month functional quality of life, then for cognition, anxiety, and also depression. So in patient with aneurysmal SAH and depression, so psychotherapy, referral to psychologists and pharmacotherapy are recommended to reduce symptoms. In patient with aneurysmal SAH and coma, the early use of neurostimulant may be reasonable to promote consciousness recovery. And in patient with ASAH and depression, treatment with fluoxetine is not effective. Okay, and then for rehabilitation, early multidisciplinary team-based approach to treatment and rehabilitation is recommended to reduce the length of stay and identify discharge need. Early rehab after the ruptured aneurysm is secured is reasonable to improve functional outcome. And then for long-term recovery, counseling patient and caregivers on the high long-term risk of cognitive dysfunction can be beneficial to identify long-term needs. Okay, thank you.
Okay, are there any questions for Athirah?
So this is the first study done. So this is actually to show the effectivity of the use of adenosine intraoperatively. However, they use the mean dose of 51.8 mg. So
what was the protocol in this study? Did you read the protocol on how did they use the adenosine?
this one I didn't read, but the second study, okay, they compare two different dosing method of adenosine. First is in a test incremental manner. First, they start with 6 to 12 mg, and then they tapered up the dose. Versus they pre-calculated the adenosine dose according to the weight. So this study found out that the second method of pre-calculated adenosine dose is more convenient, and it did not result in serious cardiologic problem, as according to the first method, there's 2 patients actually developed AF based on the dose.
So why, based on your reading, why did they consider adenosine? What is the indication for adenosine when there's an aneurysm rupture?
First is to induce temporary profound hypotension. First is to facilitate exposure, especially during uncontrolled bleeding.
Can you just go back to the paper? So it's not just the hypotension, but more important is the asystole. So when there's asystole, then there is no cardiac output. When there's no cardiac output, there's no bleeding from the aneurysm, and that will help the surgeon get exposure, and the surgeon can do clipping or temporary clipping or whatever that is required. So I think a few months back, there was one case where I actually did give adenosine to induce asystole to help our neurosurgeon to clip the aneurysm as it did rupture intra-op. Any other questions? Did I answer your question? I mean, you can do incremental or you can do estimated. If you want to do estimated, okay lah. Let's say, if you want to make it easy, you just give 3 meals Or if you want to make it, just give 18 milligram as a so-called pre-calculated dose. Because our adenosine is 6 mg per meal, right?
Yep.
Our adenosine is 6 mg per meal. So you can give like 3 meals, so there will be almost 0.3 mg kg. Of course, in my case, I gave 6 milligram only. So 6 milligram of adenosine will only get you like 5 seconds of assistance. But of course, you should not get assistance yourself. You know that when you give adenosine, there will be induced assistance. So you expect that period is as a period for the surgeon to get the clipping done. It's very, 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 very rare. I mean, I would say it's very, 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 very rare, but you should know that it is the incidence of aneurysm rupture intraoperatively is definitely not 0. So I have experienced a few as an MO, so one as a specialist here. So the incidence is not 0, and you should always have in your mind a plan on how to limit the damage from intraoperative aneurysmal bleed. So some surgeons, they might ask for a dose of thiopentone in the so-called name of inducing, suppressing the CMR02, so that if they say it ruptures, there's not much damage. So some surgeons
they have no plans for that. So some surgeons, they may decide on temporary clipping. So you know that if you temporarily clip, you know that the surgeon is clipping the blood supply to the part of the brain that has nothing to do with the aneurysm. So there's a potential risk of ischemia. So that's why there's some part of the discussion on the surgical technique is how long can you do temporary clipping. So then in that case, then how are you going to manage the hemodynamics? So then you can discuss with the surgeon on their preferences. And so if let's say the surgeon wants a slightly higher blood pressure during temporary clipping, then you try to facilitate that. So, but one thing that is not mentioned in this AHA guidelines is regarding the understanding the transmural pressure. Yeah. Is that correct? It's not stated, right? So how do you understand the transmural pressure in a patient with aneurysm? Athirah.
Not sure.
I mean, what is the interaction? So you have the transmural pressure is the NAP, the blood pressure inside the blood vessel, which includes the aneurysm. And so what would be the counteracting pressure?
ICP.
And the ICP. So as if a patient has a relatively high ICP, they will actually limit the transmural pressure. So that's why if let's say your ICP is high, then you need to think about one. Of course, you need to think about the CTP, but you also need to think about the transmural pressure. So in that sense, the risk of re-rupture may not be as high as when the dura is open. Because when the dura is open, then the ICP becomes 0. So there's no counter pressure. So when there's no counter pressure, then whatever pressure that is transmitted through the patient's cardiovascular system will be transmitted to the aneurysm without any counter pressure. And during that case, then the risk of rupture is higher. So can you go back regarding the paralysis part?
Paralysis.
There was some comment regarding paralysis, right? Absolute paralysis. Do you see absolute paralysis being done in your practice? Yeah, do we perform absolute paralysis in our practice here? When our neurosurgeon performs clipping?
No.
Why not? Usually, what kind of anesthetic technique do you observe? Have you seen an aneurysm clipping before? No. Okay. No, also. Okay. So what technique was used in your case for aneurysm clipping? GA lah. But GA with what?
Oh, bis.
Volatile? Propofol? Volatile. And then? Opioid? Are you sure? Remy? Ada? Shaking vision? Oh, okay. That's very rare. Okay lah. So let's say in general I mean every center has their own preference. Every entity has their own preference. Personally, I don't practice absolute paralysis because almost all I mean my clipping cases will be exclusively with remifentanil. And you know that with remifentanil there is a muscle paralysis effect. So most patients will not require additional paralytics, even though it will be good, but I don't find it needed when I handle aneurysm cases. But let's say if I do not use remifentanil for whatever reason, then of course absolute paralysis is a must, and then in that case an MBA infusion would be desired. So Athirah, how would I know that I achieved absolute paralysis in that case?
The use of neuromonitoring.
So which modality will you use?
TOF. 24
Okay,
count.
so let's say the TOF is 0. Does that mean absolute paralysis?
It wouldn't be accurate.
What else? On top of TOF?
DBS?
DBS. Did we use DBS for intra-op monitoring? No.
No.
So what modality would be needed to assess absolute paralysis? PTC. PTC, post-tetanic count. So you know that the closer that the post-tetanic count is, the closer it is to 15, you know you are closer to your first twitch. So if you can get like a very low PTC, let's say 3, 4, and then you know that you are very far away from your first twitch. But like I said, in my cases, I do not use an MBA in general, and instead rely on remifentanil. Okay, so what else? Any other questions? So can you go back to the EVD versus lumbar drain? Okay. So what is generally practiced here?
EVD.
EVD. So in this study, what did they recommend?
They found out that lumbar drain has a lower numbers of patients developing primary and secondary complications, such as delayed cerebral ischemia, lesser ventilated days.
So why do you think we are not practicing this one in general?
I think
Why don't we do lumbar drains in general?
because not sure.
Maybe you have to ask our neurosurgeon. Of course, one thing that we have to keep in mind is EVD. I think as an anesthetist, I think that an EVD is much more convenient. Much more convenient because let's say if the surgeon inserts it during the surgical setting, it's in the same setting as the clipping. Or if it's inserted pre-op in a patient with a poor DCS, it's probably much more convenient to have an EVD. Maybe another thing that we can also discuss with our neurosurgeon is regarding the risk of herniation. How safe is it to do a lumbar drain? Because typically, let's say if you have a meningitis case and then you have you have hydrocephalus, you do not do a lumbar puncture because of the risk of herniation. But here instead, they are doing lumbar drain, which is basically CSF drainage, and it doesn't seem to be causing herniation. So maybe the idea that you cannot deviate CSF through the lumbar drain versus intraventricular versus through the ventricle, probably not as unsafe as what we typically thought of. And then the other thing, if you think about you want to do a lumbar drain, you have to position the patient. It's a non-surgical setting, and so you have to, especially if the patient has a poor GCS, then you need to position in the ICU, and then the surgeon has to do a blind procedure as compared to an EVD where it's even though it is still blind per se, but it's much more calculated. It's much more calculated and directed towards the ventricle based on the CT scan and the surface anatomy. I mean, even for anesthetists, a lot of us of the junior anesthetists may not be so comfortable doing a spinal block under lateral position. So you just imagine now the surgeon is going to do that, which is much even less frequent procedure. So there may be difficulties.
Mm.
Any other questions? Hmm. So then in that case, in terms of the anti-epileptic, are you gonna tell our neurosurgeon? I think all patients should be on Keppra.
I think I should tell the pharmacist lah that instead.
Ah.
A lot of things should be considered.
So how would reading this guideline change your practice as regards to how you care for your patients? I know that you have never taken care of a clipping case, but I'm sure you've seen SAH cases in the ICU. So how would this paper change your management? How would this guideline change your management?
First is intraoperatively, I would be more aware of the patient vitals. Not only that, patients GM temperature, closer monitoring of patient's temperature. That one is intraoperatively. Then post-operatively, the duration, especially duration of anti-epileptics, because I think some of the patient in the ICU hybrid has been, patient post-clipping in ICU hybrid has been on anti-epileptics of more than 7 days. Probably I can argue with Mr. Goh regarding that. And then the duration of, actually I've asked Mr. Goh regarding the duration of oral nimodipine, where they practice here is a total of 21 days. However, according to this literature, they suggested a duration of only 7 days. So, itulah.
So I think in terms of nimodipine, they only recommended 1 week because of no benefit, right?
Yep.
Not necessarily because of harm, right?
Yep.
So I think, of course, if we forward this review to him, then maybe fine in terms of nimodipine use. Maybe he can shorten it and lessen the cost. Okay, but in terms of anti-epileptic duration, I think that's where our role comes in. So our role comes in terms of discussing with the neurosurgeon time and time again. So that's why we are, even though the neurosurgeon is the one that prescribed the anti-epileptic, of course, based on this appraisal, based on these guidelines, Keppra is probably better than phenytoin, and maybe we can convince that would be the default for the future, assuming that there are no prohibitive costs with the use of Keppra versus phenytoin. But of course, when you do your rounds in the ICU and you see the patient, then you always have to take into account how long was the patient on anti-epileptics and what was the indication for it. So if let's say if the patient did not have any features of seizures and the bleed was not of a high risk according to the neurosurgeon, then you need to ask the neurosurgeon to think about the duration. So regarding the temperature, what did you mean by after this you would want to take care of the patient's temperature?
I mean, maintain normothermia.
So how would you do that?
Temperature monitoring.
Temperature monitoring. So that's the first step. So I think you need to remember whenever you do a neurosurgical case, I think you should make it routine to always monitor almost exclusively all neurosurgical cases. There are only probably a few that you not need to monitor because of the nature of the procedure. But a lot of neurosurgical cases you have to it's a must for you to monitor because neurosurgical cases can develop hyperthermia, and that's also dangerous to the patient. And even though hypothermia not so dangerous in terms of the brain, there's no benefit, right? But they may be harm in terms of the other systemic effects of hypothermia. So you just have to monitor, and based on that, you have to warm the patient or cool the patient or give the patient paracetamol based on that. Any other questions?
No.
Too much.
Too much.
Shafika? Oh, okay. I think we just one thing we need to be mindful is that in our center there's a lot of things we don't have. So we don't have IR. So when we don't have IR, we do not have like a proper pre-op DSA. We have no option for coiling. So I think I can remember the trial. Is it the IHAS trial, ISAC trial? So the ISAC trial just show that there's a better outcome with coiling versus clipping. Overall. But since we do not have interventional radiology here, then of course all aneurysms will have to be managed by clipping because that's the only modality available. And then the other thing is that if the patient has a drop in GCS and the suspected delayed cerebral ischemia or cerebral vasospasm, then we also do not have IR facility to diagnose. So I think maybe that's one reason why maybe our surgeons prefer to just continue nimodipine for a longer duration, because there's no way for us to accurately detect the presence of cerebral vasospasm, because we don't have the radiological modalities. Okay. The online people have no questions.
Thank you.
Okay, so if that's the case, then I think we'll thank Athirah in the usual manner. And that, thank you.
Thank you.